to come on. It's been it's been a rocky last couple of weeks, but I'm back on live, and I really wanted to share some interesting stories that I had with patients today. Some things that really blew my mind, and I got to say, shocked everyone else in the OR with me. And yeah, it involves anesthesia and the power of the mind, as a couple of patients were falling asleep, and more importantly, how they woke up. So, I hope you guys are excited. I am super stoked because I had one patient who was like 230-ish pounds, like super muscular, very large wrestler. And what typically happens for these type of patients, hey everyone who's come on, I love it. David, Heidi, good to see you. Pika, Kirby, good to see you all. I had a patient that very muscular and in the sub 18-year-old range. Pediatric patients wake up very typically violent and aggressive. We don't quite know why. We know it's related to preoperative anxiety state, depends on the medications they got, but overall, pediatric patients wake up wild often. So we have to use special medications to actually kind of sedate them as they're waking up from anesthesia. It's really interesting. And hey, Margaret, good to see you. Hello. So I had this patient today, and this is the last person I want to wake up aggressive, because if they wake up aggressive, I'm in the line of fire here. Remember, when I'm your anesthesiologist, I'm right above you. I'm right next to your head. Patients typically go like this when they're waking up. It's actually super interesting. I don't know if you know this, but lots of mammals, when they are stressed, go into a stress response where mammals tend to contract their muscles, do this kind of posturing, fetal position almost. Well, if you're waking up from anesthesia, what does a fetal position look like when you're on your back? You curl up, your hands go up. Either trying to pull out the breathing tube from your mouth, but you're not awake enough or coordinated enough to grab the breathing tube. Instead, you typically smack the person above you. And the person above you is your anesthesiologist, or yours truly, someone who does not want to be smacked, right? So I want patients to wake up obviously smoothly, peacefully, not only for myself, but also for their safety as well. Did you know that patients can injure themselves as well? If they're waking up violent, they might scratch their eyes, pull out their breathing tube prematurely. Many things can go wrong, right? But anyway, how do I tip the odds in my favor and in the patient's favor ultimately to wake up smoothly? Well, the patient confessed to me how terrified they were before they fell asleep. All right. Now, what can I do when somebody is telling me how anxious they are? Oh, April, and how interesting. I love your observation there, April. And Chris, Chris, hold on. When I was 16, Chris says, when I was 16, I had my first spinal fusion. They were scared because I wasn't waking up. My mom said my nickname and I woke up easily. Chris, I have stories about that as well. Oh my gosh, so many stories. But I gotta finish this one first. Did somebody hit me this way? No. Gazaya, let me finish my story. The patient woke up like an angel. What did I do before they fell asleep? I did something, unfortunately, in the modern medical model here in the West, we don't really have a lot of time for touchy-feely kumbaya stuff. There's a lot of stigma against it. Same reason maybe why we have stigma against mental health things, anxiety, depression, PTSD, etc. So, I actually asked others to leave for a moment, and I sat down, eye to eye, heart to heart, hand on the shoulder, and just asked, what are you anxious about? They told me, you can tell in their eyes when someone, especially a young child, is very anxious. There were social situations as well going on, not uncommon. And hello, Angela, and hello, Amy, and hello, April. April says that she woke up crying. Well, we'll get to that in a second as well. But young child, when I asked about what was causing their anxiety, it was the anesthesia fears, the surgery fears, and all of the above. Well, it's very broad, right? So what do we talk about? About anxiety and control are kind of mutually exclusive, because when you have control of your situation, you're less likely to be anxious. That's why I've connected myself to the monitor here for you guys to see. This is just an EKG, no other fancy monitors here. But when I explained to them how much power you can have, even in that moment of terror, when you have medications on board that are kind of taking away you're feeling kind of loopy, maybe you have an oxygen mask on, you're giving up a lot of your agency. You're literally strapped down to a table. But how can you find purpose and control in that moment to not fall victim to uncontrollable anxiety, which may cause you to wake up, like I said, with me getting hit in the nose, which I don't want. And hey, Layla, good to see you from Eastern Montana. Oh, and someone else came in from the UK. RJA, good to see you again. And Brandy, good to see you. So, 30 seconds is all it took. I sat down with them, like I said, eye to eye, heart to heart, and I just told them I'm going to be with them there the whole time. They're going to be cared for, guided, cared for. Everyone in the room, they're the most important person to everyone in the operating room for the next hour and change. Anyway, I could tell based off the monitors how their anxiety was changing, because we can tell from the monitors how your anxiety changes. We can tell your mental health state from the monitors, right? Anyway, patient fell asleep in a peaceful state, and the young child, 230 pounds, who was at risk of waking up completely violent, woke up like an angel. I gotta say, the whole operating room was very pleased. I was very pleased, but more importantly, this meant the patient got fewer medications, less chance of complications in their waking up. Because when you wake up crying, screaming, maybe hurting yourself, well, you might physically hurt yourself, but there is a risk, not well studied at all. We don't know yet. But the number of patients who have told me that they have PTSD from being in the operating room, we know that PTSD is augmented. The volume gets cranked up when you are in a high stress state when the inciting trauma happens. So you tell me, please, comment below. Tell me, what do you think if the patient is waking up, kicking, screaming, crying, agitated, aggressive? Is that more or less likely to consolidate that memory in the PTSD category or in the MET whatever category? Or better yet, maybe in a healing category, which yes, that third category does exist. What do you think? Right, even in the absence of other evidence to guide us in this. I don't want to go on a leap of faith here, but I want to go with what common sense might dictate, especially when we don't have any adverse side effects to be concerned about. So let's see, what have I missed in the comments here? Awake craniotomy, Josie, I'd be happy to talk about. If you still want to hear that, Josie, let me know below. The drifting feelings, Sue, we can talk about those, but I want to make sure you guys are still on if you want me to answer those. Undesired effects of fentanyl, absolutely, we can talk about that as well. Jill Kessner says, I had an anesthesiologist that made me feel better because he had a family member with heads. Well, I'm happy you had an anesthesiologist who was able to help you with that. Margaret. Okay, well, I'm not seeing people. Okay, here we go. Now the comments are coming in. Yes, Josie and others agree that in the absence of other data, I don't need more randomized clinical trials to suggest how important it is for patients to be at ease, to be confident in their decision to be having surgery, and to feel loved, cared for, and guided. Even in those moments of so much anxiety, terror, fear, right? And that's what we were able to accomplish with that patient today. I will say, I had another patient afterwards who fell asleep. There was a language barrier. And when that patient fell asleep, I wasn't able to have the exact same kind of heart-to-heart thing because of the language barrier. And unfortunately, they woke up so anxious, they had to be put back to sleep today. Had to be put back to sleep. I don't know if you knew that, but if a patient wakes up very aggressive, they have to be put back to sleep for a second shot to wake up. They have to be put back to sleep again with this here, and that was what happened. It's just a complete contrast, unfortunately, and these are the realities of our minds and bodies under anesthesia. Now let's get to our questions here. Heidi's right. Great questions. Margaret's asking, a person on oxygen, is it dangerous to be put under? Margaret, if you have existing oxygen needs, like you have nasal cannula requirements at home, yes, there are more risks with anesthesia. Absolutely. That's correct. Brandy says, I had my esophagus stretched, and when they took me into the OR, they went to put me to sleep, I started coughing. Why did you start coughing? Depends on what medications you got. Maybe they sprayed something in the back of your throat, and that can be irritating. Benzocaine or other types of local anesthetics cause patients to cough. Perhaps it was that before your EGD. Melissa says, my anesthesia awareness during my spinal fusion surgery. What can I do to come over this? Oh, Melissa, you have to remind me, did you wake up crying? Or was that... Melissa, pardon me, could you please remind us what was your experience that you wanted to avoid? And I'm happy to give you my thoughts on that. Jill Kestner. A family member had, hypermobile Ehlers-Danlos syndrome. So Jill here is mentioning how she felt relief from her anxiety when her anesthesiologist was able to forge a connection with her, because the anesthesiologist had a family member with the same condition that Jill had. Once again, no medications. Now guys, don't worry, I use medications when needed, but this anesthesiologist didn't have to give any medications, but was able to put Jill's mind at ease with a human connection, even in the most stressful moment, perhaps, of Jill's life, or one of the most stressful moments. If we can do this, we don't need to have patients who have mutual health conditions with family members to accomplish this, right? Something we can all do with each other, and it doesn't have to be in the operating room. Yes, I am in an operating room. I'll give you a quick little look at it here. This is an operating room, and yes, TVs, lights, things from the ceiling. We can do these things in other walks of life as well. It doesn't have to be in the stressful moments before surgery that we do this. And that's what I want people to take away, that these connections are so much more valuable and so much more abstractable than simply before surgery. Great. Melissa says she felt everything. Okay. Melissa was asking earlier, how can she not have a repeat experience of her upcoming surgery from her past experience? She says, I felt everything. I woke up to my spine surgeon pounding my disc into my spine from the inside. I could feel, hear everything, but I couldn't open my eyes or speak. She woke up in the middle of surgery. Melissa, there's a couple of things here about spine surgery. First of all, my heart goes out to you. That can be super, that's needless to say, traumatic, and I'm so sorry that you experienced that. My first question for you is, did you feel pain or did you feel the pounding? Because there is a difference. Number two, when we have awareness under anesthesia, it's typically because of an underdosing of anesthesia. Many things can cause us to perhaps underdose the amount of anesthesia that you give. Depends on how much anesthesia you need relative to how much we're giving, which is dependent on how safe it is for your body. Patients that have heart or lung problems may not be able to tolerate as much anesthesia as they may need. Other things that may increase the risk of awareness are things that increase your anesthesia needs, like marijuana use, alcohol use, red hair, a little bit more requirements. It's not significantly more, maybe in the 10 to 20% range. But in the case of someone having spine surgery, special anesthesia techniques need to be used that may increase the risk of awareness. It's called neuromonitoring. We can't use our traditional anesthesia gases that come out of our ventilator. I'll show you here, right? This is a traditional ventilator here. We can't use our anesthesia gases because they interfere with the safety of many spine surgeries. Because they need to, we can go into it if you'd like, but we have to use different medications which may increase the risk of awareness. The most important thing you can do is, one, if you have a PTSD experience from this, talk to a mental health professional prior to your next surgery. Two, recognize that having headphones over your ears during your next surgery, even while you're asleep, is one of our few treatments that can help patients who have had PTSD from surgery have a better surgical experience the second time around. And third, talk to your anesthesiologist well in advance, request a consultation with them to explain to them what happened so that they can review the previous anesthesia record. It's what I do with patients all the time. If they had an issue in the past, I review their anesthesia record to see what happened so I can do something differently. I don't want to repeat the same thing again. So I hope you got those three strategies there. I wish you the best of luck. April Taggett, I had to have surgery 1 hour after my best friend died. Oh my gosh. She had to have, past tense. I was hysterical. There was no way to postpone. My doctor was great. I was worried going under, upset if it would affect outcome. Well, April, Are you comfortable sharing how your outcome was after you fell asleep in that Oh, man, I'm so sorry. That's so rough. If you're comfortable sharing, I would love to know how that went. Book. My anesthesiologist asked me my favorite song to play in the OR when I got under. Does that really work? Book. Yes. Music therapy does help. There is evidence for it. It's not going to be as effective as reducing anxiety, maybe as potent GABA receptor agonists like this one here, which maybe you can see, I don't know. It's called midazolam or Versed. But yes, music therapy does have evidence for preoperative anxiety reduction, absolutely. And there's no side effects to it. Awesome, I'm so happy you had that, Book. Brandy. Brandy had an EGD, and she was wondering why she was coughing, right? EGD, dilation of her esophagus, I believe is what she said she had. I don't think they sprayed anything, but I tried to tell them that I couldn't catch my breath. They continued to put me to sleep. When I woke up, I was not a happy camper. Brandy, what causes us to not feel like we can take deep breaths in and out? Many things can do this. Anxiety absolutely can. I'm not saying that was your case. There are not any anesthesia medications in the absence of epidurals, which you would not have gotten for an EGD or an esophagogastroduodenoscopy, tongue twister, that would have caused you to feel like you can't catch your breath. I'm sorry you experienced that. I'm wondering what, I can't think of anything that would have happened in that case other than maybe being given opioids. Sometimes we use medications like fentanyl. She is not focusing here, but get the idea. These take away our respiratory drive, and they feel that we may feel an air hunger when these medications are on board. I'm sorry, it is unusual. I've never had a patient tell me that before, but I do hope that you let your next anesthesiologist know. And Melissa, going back to the spine surgery and the awareness under anesthesia, did feel pain. Melissa, once again, I'm so sorry that you experienced that, and I do hope that you take those 3 tips with you moving forward. Tom is asking, is it normal for patients to have a pre-med before having surgery? Yes, it is very common with the medications that I showed here. This one is in a dark vial typically because it degrades in sunlight. It's called midazolam. Good question. Kelly says, I had to be put to sleep for an MRI, and when I woke up, my O2 levels would not be above 84. Is this because of too much anesthesia? Kelly, they must have gone up above 84 at some point because you're still talking to us today. I don't know when they went above 84, but 84% is incompatible with life. Mine is no longer on here because I don't have the finger monitor. I had the other monitor I put on my lip earlier that you saw my oxygen saturation with on TikTok Live. But anyways, you must have come up above 84% at one point. I don't know. It really depends on when it went up before I can comment on what may have caused it to dip down. The most common cause is what's called hypoventilation because of the central nervous system effects of this medication called propofol. It is the typical agent used in the MRI. Because when you're in the MRI, we typically don't have breathing tubes in place. If it's an outpatient MRI, you go in, you breathe without a breathing tube with a propofol infusion in your IV. And that causes hypoventilation, literally not breathing as much as you need, and that causes the oxygen saturation to drop. Good question. Pat has AFib and bradycardia. Might be getting a pacemaker. What kind of anesthesia is used? Usually sedation is used for pacemaker implants. Sedation in the form of the midazolam that we talked about earlier and the fentanyl. Good question. Very good question. Usually an anesthesiologist is not there for that. Chris, I panicked when my doc put the mask on me. I was freaking out. The doc talked to me. Because I had asked, he held my hand. I then went down pretty peacefully and woke up calm. Chris B, can you please remind us what surgery you were having done? That is such a powerful, such a powerful experience. Dr. Hope. Very perfect, Chris. Thank you for sharing that. Nicole is saying, I had an endoscopy and a colonoscopy at the same time. I woke up screaming and crying. They had to calm me down. Well, Nicole, I'm sorry that you had that. I do wonder if you had an anesthesiologist or if you had nurse-administered sedation. That does change. It sounds like you may have had nurse-administered sedation because when I have patients who are nearly under general anesthesia for an EGD and a colonoscopy, they don't really wake up crying because they're under anesthesia. A quick shout out, guys, if you are learning something, do please hit that like button and Share with others. I do try to put videos on here every week that go into more discussion about the powers of the mind and body, and I would love to get your input on the next video that I do this week. So do feel free to let me know below and to share with others, and hit that subscribe button if you're learning stuff. Kelly says it took 2 hours for her oxygen saturation to rise after MRI sedation. Well, that's a tough one. 2 hours. I do wonder if maybe you didn't have a little mini aspiration episode, or if what's called atelectasis. Atelectasis is when your lungs collapse on themselves under anesthesia, and that's why we have those incentive spirometry devices where you go and a little ball goes up and you have to play the game to bring the ball up. Did you have one of those devices that they gave you, Kelly? That may have been it. Okay. Deanna, I love how you call your patients the night before surgery. I've had 4 surgeries this year. Oh my gosh, I'm sorry, Deanna. 3 under general, none of my anesthesiologists called. Well, Deanna, thank you so much for the kind words. I wish you the best for I hope you don't need to have any more surgeries, but I hope that your recovery is going smoothly. RJA World is sharing that they woke up dazed and confused, but all good. It's good to hear that. Jill says, is it true that patients with Ehlers-Danlos need more anesthesia? Most likely it comes from, we believe, connective tissue changes that don't let the lidocaine, like this guy here, the local anesthetic, it doesn't let it spread. You can't even read that, can you? The lidocaine does not spread when the connective tissue is not expanding. You know, when we do an injection, if it doesn't spread, it can't numb up the nerves. So that's why we believe patients with Ehlers-Danlos may have increased requirements for some anesthetics. That's right. Do I like ketamine as a form of sedation? Brendan, yes and no. Depends on the procedure, depends on the patient. Very good question. Let me know below if you want to know more about that. Brandy, thank you for the kind comments. I appreciate that. Nicole had an anesthesiologist and woke up crying. So Nicole, what happens in colonoscopy, so Nicole is saying that when she had her double GI, her EGD, and the colonoscopy up the bottom end, she woke up at some point screaming or being uncomfortable, right? This happens when a patient is not breathing well because you don't have a breathing tube in for these procedures typically. And if some patients get a little bit too much of the white stuff and then they don't breathe well anymore, then we have to actually we have to turn off the propofol infusion, which may cause them to wake up. So if you were not breathing well at some point, the anesthesiologist may have had to turn off the propofol, which would have led to a relative underdosing. This is why I always recommend my patients to get their sleep apnea under control, because the more you use your CPAP machine, and when you have a normal body weight, the less likely you are to get too much propofol to stop breathing and then have to have the propofol turn off so that you remember things and wake up. It's a balance. Anesthesia is a balance. And the health that you bring into the surgery or into the operating room or the procedure room determines what your surgery is going to look like. Sophia, you're welcome. Thank you so much for the kind comments. Heidi, thank you so much for your comments, Heidi. I love it. What does it mean if you have low oxygen and blood pressure and end up with a lower half-collapsed lung? A collapsed lung, called a pneumothorax, different than the atelectasis that I mentioned earlier. A collapsed lung is very serious because when you have a pneumothorax, and this is actually super dangerous in the operating room, because when you're connected to a ventilator, a pneumothorax can be lethal. It can kill you. Pneumothorax means that your lung is collapsed because other air is in your chest, but not in your lungs. So you got to ask yourself, how can you have air in your chest, but not in your lungs? It's because the air is in cavities outside your lungs, and that air pushes the lungs down in a way, and it collapses them. A ventilator might be pushing air into that air cavity and thereby pushing the lungs down even more. That's how you can die. It causes low blood pressure because as it's collapsing the lungs, it can also collapse the inferior vena cava and reduce what's called venous return to the heart, hence why it's lethal. So we need to place what's called the chest tube very, very quickly, or else stick an IV needle into the chest. Good question, Heidi. anything to release that air cavity. Once again, if you guys are learning stuff, do please hit that like button, and I would love to get ideas for what you want the next video to be that I do this week. I'm super excited to do it. Nicole is saying, after every operation, I've woken up screaming and crying. Is that normal? It is not normal, but it is common. And I do suggest that you talk to your anesthesiologist about it to try to figure out what the reason may have been. All right. Pat, you're welcome. You're welcome, Pat. Josie is asking about seizures under anesthesia. I kept having seizures even with propofol and cold water. They could not get them to stop. I've had 5 brain surgeries for FCD. I don't know what FCD stands for, but seizures are very rare under anesthesia because propofol and anesthetic gases turn off the brain and thereby turn off seizure activity. But brain surgery is different. In brain surgery, you are directly manipulating the brain, and that can cause seizures that may be more refractory to the typical anesthesia that patients get. So brain surgery is a whole different category. We actually give prophylactic or preventive anti-seizure medications, usually in the form of Keppra or levetiracetam, just because that's a very different, that's unique in all the surgeries we do for its seizure risk. Very good question. Do I call it Jackson juice? No, we don't. Diana, she has had 4 eye surgeries. Well, I'm happy that you had good experiences with your anesthesia, Diana, for those eye surgeries. Robert's asking, when do I use a Goodle airway? I had to use one today. Robert, that's a good question. I don't know if I can answer that right now. I may have to do a whole video on that. All right. You know what? Maybe we'll end with that. Maybe we'll end with that. Robert's asking, when do I use this airway? All right. So this airway here is called an oral airway, I think this is what you're referring to as a Goodle airway. We use this when it's a sedation case, when we're not placing that long, kind of suspicious-looking tube down your throat. You know what I'm talking about. You've seen those in other videos. When we place that oral airway, it helps move your tongue out of the way so that you don't obstruct on your tongue, don't snore. Now, if you're in a sedation case, it's preferable because that way I don't have to place a breathing tube that may give you a risk of sore throat, hoarseness, or dental damage. However, that oral airway may not be sufficient for some if you don't have enough respiratory drive to breathe on your own. 2, it does not prevent against laryngospasm. So it's always many subtleties that go into these decisions for which airway we choose. I do like that one because it's typically less invasive and less chance of side effects. Great question. All right. I'll just end by saying, Chris, we are the best at placing IVs because we place probably more IVs than anyone else, at least under ultrasound, and we have so many techniques for doing them when you're awake or asleep. But many other nurses do them, I know, and many other doctors do them, and a lot of us do IVs. So thank you for the kind comment there. Nicole, I said I would end, but Nicole asked such a good question. She had an aspiration pneumonia after an endoscopy. So that's very serious, Nicole. And actually, Sophia asked about aspiration. Oh my gosh. All right, I guess I'll answer this, and then that'll be the last question. Aspiration is very dangerous because your lungs are very sensitive. When you aspirate stomach acid, meaning you vomited acid up and you breathed it into your lungs, you now have pH 2.5, 3.5 chemicals in your lungs that will burn the surface of your lungs very fast and cause a chemical pneumonitis. If you burn your lungs, you can't exchange oxygen through your lungs. That can cause your oxygen saturation to drop, and it can lead to pneumonia or an infection, like a bacterial infection after. What do we do when it happens? It's actually called supportive care. We don't have anything to treat it unless there's an infection, in which case we treat the infection. This is why the prevention of aspiration is the most important thing, which is why when I call my patients the night before, I always ask them that please take your Prilosec or whatever you take in the morning for acid reflux. If you have it, take that in the morning because we believe that might increase your risk of aspirating stomach acid. Because remember, if you've taken your proton pump inhibitor, if you do aspirate, it's less likely to be acidic stomach contents. I also ask them to not eat a heavy meal or a greasy meal if they have acid reflux, because I don't want them to wake up in the morning with acid in their stomach and then increase the risk of aspiration that way. So you always have to follow whatever your anesthesiologist tells you, but that's what I always advise my patients depending on their surgery. Diana, Karma, oh, you think our dog should have another dog for company? You know that she has a cat that she plays with, right? They're like BFFs. You've seen the videos of them licking and playing with each other, right? So I think that they have good company. So, Lone Star, good to see you. Yeah, my patients don't have issues with propofol because I actually use lidocaine with it. And the lidocaine, so I always have them together because that helps remove the pain when it's being injected. Okay, Pika Kirby, last question, and I'm gonna go. Can you request to be under general anesthesia instead of sedation if you don't have any risks? You can always request, but it does depend on whatever is safest for you, and your anesthesiologist will decide that. All right. I wish everyone a good rest of the day. I am going to ask you guys one more time, if you have requests for what you want me to do my next video on, let me know in a comment on YouTube or find some way of letting me know. I would love to have a video that's interesting for you guys. And I'm really thinking maybe of doing my top 3 natural remedies for pain after surgery or even without surgery. I'm curious to know what you think, if you would like that or not. So do let me know. And have a good rest of the day, everyone. I hope to see you guys again soon. Remember that you have more power over your health than you've ever been told. And sorry, I think I'll do my breathing exercises next time so you can see my EKG change with my breathing. I love to do that. We didn't get to it today, but we'll do it next time. So, no stress about that. See you guys soon. Bye-bye, Pika Kirby. Take care.